7 days. That is the newborn care baseline, but documented medical necessity can extend it. Professor Yuki Lindqvist joins us to read the newborn statute beside the hospital clock. Stay with us, because in Scene 5 we'll give you the exact call that keeps a medically necessary extension from becoming a billing mystery.
Start with the clock itself. VA's May 2026 guide says newborn care begins on the date of birth and continues through the next 7 calendar days. That is 8 calendar dates when you count the birth date, not a vague week after discharge.
Let me back up. The newer question is, what happens when the baby still needs care after that baseline window?
Before we crown that exception, I want to stress test it. Families will hear 7 days as a hard stop, so the extension sounds like,
The statute itself makes the exception explicit, Fenrir. Section 1786 starts with not more than 7 days, then allows longer care when the newborn needs additional services based on medical necessity. The ordinary benefit also includes required inpatient and outpatient post-delivery care, and VA's current copay guide marks covered maternity and initial newborn care as no copay across priority groups.
hard stop claim loses. 7 days is a front door. Medical necessity keeps care open.
I can't speak to another insurer's enrollment rules. That is a different lane. For this statute, one boundary deserves daylight. Initial newborn care and the veteran's postpartum care can run beside each other, but they aren't the same benefit record. A mother may still be receiving postpartum services after the newborn baseline closes. The baby's extension must stand on the baby's medical need, not on the parent's continuing appointments.
Both things are true, or rather, both clocks can run at once. That prevents a category error. Put 2 headings in the family folder: veteran maternity and postpartum care, and newborn care. The dates can overlap without being interchangeable. When the hospital calls, you want to know which patient, which authority, and which service date the conversation concerns.
2 patients, 2 clocks. A healthy newborn may leave while mother remains admitted, or reverse. Each record needs its own dates and next decision.
That distinction matters before anyone sees a bill. At vaprofessorerica.com, the free guides can help you organize the questions, but your maternity care coordinator and clinical team decide the live case.
Fenrir, give us the question a tired parent would actually ask at 2 in the morning.
Brochure, tidy, neonatal intensive care night, not tidy. Who tells VA a baby needs covered care after day 7?
Coming up, the delivery route itself decides who qualifies under the newborn statute. One thing before the next part, and then we move right on. If any of this is clicking, tap that like, hit subscribe, and ring the bell for the next one. It takes a second, it costs nothing, and it helps more than you would think.
Headlines too broad. 2 gates come first. VA Maternity Care and Delivery Authority. Prior service alone doesn't qualify a newborn under this section.
Correct. The woman veteran must be receiving maternity care furnished by VA. The delivery ordinarily occurs in a VA facility or another facility operating under VA's maternity arrangement.
And the statute now addresses the frightening edge case: delivery somewhere else before the veteran reaches the VA or contracted facility. It doesn't tell a laboring patient to solve contracting before safety.
That sounds broader than an old brochure.
That's backwards. The statute controls, emergency safety comes first. The current law includes an emergency delivery before arrival at the planned facility. Preserve the facts, don't delay safe care. Change one fact. She chose an unrelated home delivery arrangement outside VA authorization. Do not promise that the newborn statute will pay merely because maternity care exists elsewhere. The exact delivery authority matters.
Hold on, use a 4-part check. Is this pregnancy and delivery moving through VA maternity care?
I mean, there is a timing advantage to solving this before labor. A coordinator can confirm the intended facility and explain how community maternity authorization is recorded. A parent trying to reconstruct that chain from a recovery room starts with less sleep, more departments, and a newborn chart moving faster than the billing chart.
Plans change during labor. Keep VA contact, preserve why route changed, and don't rewrite emergency facts just to tidy paperwork.
Leo, preparation also means asking the coordinator how after-hours changes are reported. A planned hospital may transfer care at midnight when the familiar office is closed. The answer isn't to invent a new benefit channel. It is to know the health system's urgent contact path and preserve the clinical handoff for the coordinator.
Yes, one missing authorization fact can change which payer owns the hospital bill. That's why the coordinator belongs in the story before labor, not only after an invoice arrives.
Build a 3-item record: coordinator name, delivery facility, and maternity authorization. That gives the newborn team a precise path when care crosses departments or hospitals. Use those same 3 labels on every call. If one changes, note who changed it, when it changed, and which record now governs.
Back with us for the medical necessity rule, Professor Lindqvist. Pick up mid-sentence, the baseline clock reaches its edge, but the baby still needs oxygen monitoring.
Then what does the newborn still need? That is the medical necessity question, not whether a parent can negotiate another week. The statute gives VA discretion to furnish more than 7 days when the newborn needs additional care.
Give me a number. Another 7 days?
There is no fixed second number in Section 1786. It says more than 7 days based on medical necessity. The duration follows the documented need and VA's authorization, not a universal 14-day coupon.
I'd put real money on a clean 14. Scratch that, Yuki's actual rule just sent my confidence off the field. My telescope logs have survived steadier nights. Anyway, run the real clock.
The rule also names a case families may not expect. The baby is discharged, then needs readmission to protect health and welfare. Leaving the hospital doesn't automatically erase the medical necessity pathway.
Zinger, discharge isn't the same as clinical finish.
Exactly. But families shouldn't self-declare the extension. The treating team documents the condition and level of care. VA's maternity and community care channels need the facts required to authorize and pay the covered services.
To be precise, a useful medical necessity record answers 4 practical questions. What condition requires more care? What service is required? Where it will occur? And why stopping or delaying would be unsafe? The parent doesn't author that conclusion. The clinicians do. The parent makes sure the conclusion reaches the VA team managing the benefit.
One estimate moves, then another. Fine. Keep current clinical plan and authorization in one conversation.
Yuki, the future-facing lesson is that the authorization record should travel as quickly as the clinical record. Families can't force 2 systems to share software, but they can ask the hospital case manager and VA contact to exchange the specific documentation that supports continued newborn care. The analogy is an airport connection, not a parking meter. The first ticket establishes the route. A medically required diversion changes the itinerary, but the airline still needs the new flight recorded.
Keep that analogy. We will test it when a transfer crosses hospitals in Scene 6.
That closes the rule: no preset second clock, only documented need and a current VA care path.
Transfer makes coverage real. Delivery hospital lacks cardiac care. A pediatric center across state accepts baby.
Section 1786 directly anticipates that covered post-delivery care can occur at another facility, including a specialty pediatric hospital, when it accepts transfer and responsibility for treatment.
The transport rule works because the treating team controls the medically appropriate mode, not the parent. It can include ambulance, air ambulance, or another appropriately staffed option, plus eligible transportation for the newborn and parents. If delay would endanger life or health, emergency safety comes first.
My assumption is that covered air transport lets the parent book it and sort authorization later.
No. Approval depends on the treating team's transport order.
So if a family drives later with no clinical order, does that rule still apply? No, wait. The boundary is clinical transport, not family travel. No order, no transport benefit.
The sending facility, accepting facility, date and time, transport type, clinical reason, and every VA contact. Those aren't magic approval words. They are the facts needed to reconcile authorization, medical necessity, and payment.
More like this: A routine family ride after discharge has no clinical transfer order. Do not call that an ambulance benefit just because transportation appears in the law. The medical facts still control. Before we get to the bill, keep one transfer distinction straight. Acceptance by the receiving facility isn't a decorative detail. The statute describes another facility that accepts the newborn and responsibility for treatment. Capture the accepting service and physician when the clinical team provides them.
Parents may hear several labels at once: transport center, neonatal team, pediatric cardiology, utilization review, community care. Do not try to master every department. Ask each person for one next owner. Who sends the medical record? Who holds the authorization question? Who can confirm that the receiving facility accepted responsibility?
Distinction holds. Covered transport belongs to necessary newborn care, not a travel wallet. Even Loki couldn't drag a routine ride through that statutory gate.
Now cut the scene while the phone is ringing.
And the call begins with facts, not a legal speech. My newborn is still admitted, the baseline window is ending, and the clinical team says additional care is necessary.
That pays our opening promise. Contact the VA Maternity Care Coordinator or the VA team managing the maternity authorization as soon as continued care, transfer, or readmission becomes likely. Give the facility diagnosis level reason the team provided and the expected care path.
I would ask whether the coordinator can guarantee every charge.
No coordinator can guarantee an unseen hospital bill. Because authorization lives in another system, ask the hospital to connect utilization review or case management with the VA contact. Parents shouldn't have to translate a neonatal chart, but they can make sure the two systems know whom to call.
Can a medically necessary readmission qualify after discharge?
Once care is underway, state the timeline exactly: birth date, discharge date, new symptoms, readmission facility, and the treating clinician's reason. Seek the needed care first. The statute specifically includes a newborn who was released and requires readmission to protect health and welfare.
The VA Women's Health page is worth saving before delivery. It points veterans to maternity care coordination and the women's health resources that help locate the right team. If the coordinator is unavailable, leave a message with enough detail to route the case and use the VA contact path the maternity team previously provided. Do not leave only, call me. Say newborn continued care, transfer, or readmission, name the facility, give a callback number, and note the urgency the clinical team stated. Fenrir, keep that first message short but complete.
Let me count out loud. Patient, event, location, clinical team. Which one can we drop? None. Give all four, then exact timing. Ask whether VA has an authorization record, not whether someone can extend a coupon.
Keep a contemporaneous note: date, time, person, department, and next action. The note cannot create coverage, but it prevents 3 departments from reconstructing the conversation differently.
The procedure is now concrete. The remaining trap is what happens when the bill outruns the authorization record. Back with us is scorekeeper, Professor Lindqvist. Hospital invoice, VA payment, and patient balance are 3 separate records until they reconcile.
My guess is that a bill after day 7 proves the extension failed.
A bill proves no such thing, Fenrir.
Fine. Record follows charge, service date, facility, clinician, transport, and reason for continued care against maternity authorization and medical necessity documentation.
You can have a valid diversion while your first itinerary shows the wrong gate. You correct the record, you don't pretend the diversion never happened.
I dislike how well that survived. What protection does the statute give after VA pays?
VA's payment to the covered provider generally extinguishes the individual's liability for the covered care or transport, unless the provider rejects and refunds that payment within 30 days. That is why payment status matters before a family pays twice.
Here's what I'd actually do: reconcile before paying. To be exact, when speaking with billing, ask for the claim or account number and an itemized statement. A total alone can't show whether the disputed balance is newborn inpatient care, physician services, transport, a parent charge, or something outside the covered episode. Exact line items keep one denied category from contaminating the rest. My card catalog rule applies: 1 labeled line item per drawer, not 1 mystery total.
Or rather, ask whether the provider received a remittance or explanation from VA. The statute's patient liability protection turns on what VA paid and what the covered entity did with that payment. A customer service note saying insurance pending isn't the same as a posted payment record.
Collection notice, document dispute, and every reference number. Don't assume one call froze an account. Ask what the provider requires in writing. My first guess was wrong. A bill shows an unresolved transaction, not lost eligibility.
That is the status shift I wanted. We started with my fake 14-day certainty and your hard stop invoice. The statute supports neither shortcut. Professor Lindqvist, leave families with one final sentence.
Treat the medical record, authorization, and bill as one chain that must agree before accepting a patient balance.
Thank you, Professor Lindqvist. Call it the one-chain rule, medical record, authorization, and bill. That gives us the final plan for before delivery, continued care, and any bill.
Before delivery, save your coordinator's name and authorized facility.
During the baseline window, confirm the newborn service dates and clinical plan.
If care continues, ask whether medical necessity is documented and VA has the extension record.
If transfer happens, keep the sending hospital, accepting hospital, and transport mode together.
If readmission happens, seek care first and give VA the exact discharge and return timeline.
If a bill arrives, don't let the envelope invent the coverage decision.
I printed this out. The whole folder can fit on one page. At the top, coordinator and authorization. In the middle, birth, discharge, transfer, and readmission dates. At the bottom, provider account numbers, VA contacts, and next actions. Keep medical records themselves secure. The page is an index, not a public diary.
Hold on, that index also protects the future handoff. A partner or trusted family member can say, this is the latest authorization contact and this is the current facility, without pretending to interpret the baby's chart. Clear coordination is a practical form of support when both parents are exhausted.
One clarification. Does no copay mean a family can ignore other insurance enrollment?
No, VA newborn coverage doesn't erase a family's deadlines under an employer plan, TRICARE, Medicaid, or another insurer. Handle those enrollment rules separately and on time.
If you're watching in the waiting room, pause right here. Walk away with this. 7 calendar days is the baseline, medical necessity can extend care, and documentation connects the two. That chain keeps the care story intact for every handoff.
To borrow Leo's phrase, the one-chain rule makes a hospital bill a reconciliation task, not a verdict.
If this clarified the newborn care extension, like the video and subscribe for sourced VA benefits guides. Which fact would you save first? Your coordinator, the authorization, or the hospital service dates? Keep the care team talking to VA before the billing systems drift apart. Thanks for watching. Leo, signing off.